We are going to talk about monitoring and evaluation of a national cancer plan today. And we're so happy that you could join us. So we are fortunate to have with us today Betsy Kohler from the North American Association of Central Cancer Registries. Betsy is a partner with NCCP. And so we're happy to have her here today to give our presentation to start us off about monitoring and evaluation, hitting sort of the highlights and leaving you with some key messages and thoughts to take away about monitoring and evaluation. And then we have, I don't know if he's joined yet, but Dr. Siraj from Sri Lanka is giving the case presentation today. And so we will hear from Sri Lanka as well. So I think we want to start off with one just update for you. And I am going to, I think it's here, put it in the chat. So we got a little bit of feedback from all of you, the country team leads, about the topics and the order of presentation of topics. And so we've made a few changes. So you can see from what I put into the chat that, of course, today we're doing monitoring and evaluation. We push costing out a little bit further. That was one of the big recommendations. So we've done that. So next month, we'll talk about improving service delivery, such as decreasing the time from diagnosis to treatment. And now, right now, we have Uganda as the case presenter. So we had to change up the case presentations just a little bit because of the change of order. And then you can see the rest. So in May, we'll do a midpoint progress review. That's when we'll ask all of you to present about the progress that you're making on that priority or two that you identified during the focus group discussions. And then we'll tackle costing and financing in June. And then in July, integration with other chronic disease programs and systems, mobilizing health workforce, September, supporting research, in October, just sustaining efforts. So that is our capstone session. That's our last session for this cohort of the ECHO. So that's our plan. We will post this updated topic list with the assignments for case presentation on Basecamp. So you'll be able to find it there. And with that, I think we want to actually switch the order of things a little bit. We're going to do the question. We have a poll question for you. And so Clay, if you all can go ahead and launch that, that would be great. So you can see we have two questions here. You should be able to see them, but if you can't, you can just scroll down a little bit. The first one is our objectives and strategies related to monitoring and evaluation of the plan included in your National Cancer Control Plan. So if you could just go in and mark yes or no, that would be great. And I see no one has answered yet. So hopefully you can see the poll.
Yeah, it's not showing up on my
Okay,
screen.
there we go. Everybody can see it now? Okay, so Clay, do you want to just say something? It could be something about whether or not your Zoom is updated.
Yes, it could be with that too, Leslie. If they're not on the same client as us, they may not pop up. If I need to, I could restart the poll, but it's up to you guys.
I think it's okay. Let's let it go. We've had a few answers so far. But if you aren't seeing the poll, that could be what it is that your Zoom is not up to date. So after this, you might want to update it. And then we are asking you, the second question is share one strategy from the plan. So what's in your plan related to monitoring and evaluation? For example, capacity building, improving use of data, increasing resources. So we've got 3 out of 4 people who've answered that. We'll give it just another minute. This is a new feature. You can do short answer polls. Give it just another minute. See if anybody else wants to come in and participate. Okay. I think we can go ahead and show the results. I think it gives us a quick. All right, so everyone said that there are objectives and strategies related to monitoring and evaluation in the plan, which is great. And then short answers around what are the strategies, capacity building, improving use of evaluation data, and human capacity building. So a lot about staffing and training to do monitoring and evaluation. Thank you all so much for answering that. Okay, so that's good. That's good for you. Betsy, a little bit of info to start off. So Betsy Kohler is the Executive Director of NACER, and we're really happy to have you here with us, Betsy. So I'll let you take it away and
All
share
right.
the screen.
There you go. Can everybody see?
Yes.
Okay, great. So I'm going to talk about monitoring and evaluation of national cancer control plans. And my slide is not advancing, although I'm using that key.
If you click on the right side of the screen on the PowerPoint presentation, it should allow you to advance slides. If not, you
There we
click.
go.
There you go.
Okay, thanks.
No problem.
So my first point is that data are really the heart of a national cancer control plan. They're used in all phases of cancer control planning, including what I call pre-planning, is making a case for a cancer control plan. How you need data in order to even influence legislators or policymakers that you need a cancer control plan. I mean, we all understand the importance of cancer control plans, but that's not always understood by funders and policymakers and the public. Planning. Data are needed for establishing our priorities. We're deciding where we can make the most impact, using local data to focus in on where we want to make a difference. Then during the monitoring phase, we need data to assess how we're doing and whether we need to change our strategies or modify them to reach the populations that we want to reach. And then in the evaluation phase, to answer the questions about whether we've accomplished our goals, how do we improve if we haven't, and what's next? You know, the concept of completing the circle and going back to the planning phase for the next phase of what we want to do. So why are data important? Data support evidence-based decision-making. I'm sure you've heard this a lot. It allows for targeting of resources to meet specialized needs of a community, and really policy needs to be based on data, not the whims of individuals or policymakers. It's really the key to building a strong story about cancer and cancer control. And ultimately what we want to do is shape policy for improved health and longer life. So we need numbers to back up what we're trying to do. The numbers of new cancers, cancer incidence and mortality are important. The number of deaths, the number of people living with cancer is also something that we might want to think about. But we also need other types of data, including information on risk factors, behaviors, and demographics in order to, again, assess the burden and predict for future trends. And to look at local data to determine where to invest scarce resources for the greatest effect. So determining the burden of cancer, we need data to assess the problem. As I said, you know, if somebody thinks that there's a lot of cancer in their community or in their country. And you say, well, why? And they say, well, you know, my neighbor, the person next door has cancer, and somebody down the street, and you know, someone in the next town has cancer. That does not really get at a factual picture of the problem. So we need real data. We need some numbers to back up that feeling that people might have. And then we want to look at who is at risk of developing cancer and look at community profiles to see what types of behaviors are common in the community. You know, what are the tobacco use boy, I'm having trouble with my words today. What are the tobacco use practices in the community? What are the dietary changes? What kinds of vaccinations are being used? And sometimes the attitudes towards those practices are important to understanding what's going on in the community. Then we need to use data to plan the actual cancer control initiatives. Where should we target our interventions, and what should they be, depending on the types of cancer that you're seeing in the community that are most prevalent. So then in the next phases, we want to use data to monitor progress. So how do we do that? What are some of the short-term processes that we can use to monitor progress in a cancer control plan? We could look at vaccination data, see about HPV vaccination, look at the number of persons screened in your programs and what the outcomes of the screening are, whether you're actually detecting new cancers. Are there new policies and or laws that have been instituted that are favorable to cancer control? And things like tobacco sales or use. That might be another thing that you might be able to monitor in the short term to measure progress with your plan. Now, some of the outcome data are longer to accumulate and more long-term, and these are usually where some of the cancer registry data may be useful to you. To monitor incidents. And with incidents, you know, it's interesting, with an initiation of a cancer control plan, incidence rates can actually go up at first because you're detecting cancers that have not progressed to a clinical stage. You're catching them earlier, so the numbers might jump up a little bit, or they may decrease. You may catch cancers that would never be diagnosed, such as colon cancer. Sometimes we can remove polyps before they turn into cancer, so the incidence would actually go down. We'd also want to monitor the mortality or the deaths. Ultimately, we want to see this go down. And the other thing we might monitor using cancer registry data is the stage of diagnosis. We want to see the stage at diagnosis trending towards the earlier stages. But these are more, these data take longer to accumulate and are probably more useful in the evaluation phase. So I talked a little bit about a population-based cancer registry, and I just want to make a point that population-based registries collect cancer information from everyone in a catchment area, like in the country, or could be in a region, but it's defined geographically, and that all the cases are counted, and that we need to take into account other characteristics of the population in order to make sense of the data that are available. So I'm sure you're all familiar with these types of graphs, just showing that incidence and mortality are common measures of common measures that are used in cancer control. We have the incidence on the left and the mortality on the right. And in many countries, we don't have these data, either the incidence or the mortality, and it makes things much more difficult to measure in the long run. So I just want to show this to remind you that the International Association for Research on Cancer has a program that supports cancer registries called the GICR program. Here's a map of their coverage. And so resources are available to you if you need to help develop a cancer registry in your country. And their functions through the regional hubs through the GICR program are training, networking, support, and cancer control, you see there. So I thought I'd throw in a slide about other types of data that you might want to consider, and that would include the age structure of your population, notably the proportion of the older people in your population. We expect more cancers in older people, so you might anticipate that there would be more cancer than in a younger population. COVID, what's the effect of COVID on the population? We're expecting and seeing in the United States and Canada and Europe the delays in diagnosis. People didn't go in for screening, or they didn't see their physician, and so cancers are being delayed. We're expecting that will result in a later stage of disease at diagnosis and potentially more complications due to COVID itself. The other population I wanted to draw attention to are children. Childhood cancer is getting a lot of attention these days. There are many fewer childhood cancers, but the burden on society is great. It affects children for the rest of their lives, and you need to consider planning for the long-term effects of children who survive cancer, and they are at higher risk for developing subsequent cancers. So it's important not to neglect the children when you're doing a cancer control plan. Other uses of data, are to educate the public so that they understand the burden of cancer. Maybe they can help modify their own behaviors and encourage them to participate in screening. They like to know about survival statistics if they're diagnosed with cancer. And then lawmakers, data again provides them with the basis for making policy decisions that will ultimately affect your cancer control plan. Others are health planners for making all types of decisions at the hospital or healthcare level, including even purchasing of supplies and anticipating how many cases of different cancers they may see. And of course, researchers always love data. And this is where we can really make some progress in looking at the etiology of cancer and the distributions of cancer across the country. I just want to point out to you as I finish up here a couple of resources that we have at NACER that are available. We do have an online discussion forum for international cancer registries on our website where anyone can post any questions or look for advice. And we are developing some online courses for international cancer registries. The first module should be ready in the next month or so, and the second module should be ready in June. I'm going to show you where you can find these. This is our homepage of our website, which is nacer.org, NAACCR.org. And if you look down on the left, there's a tile that is resources for international registries. If you click on that, you will find paths to those resources that I showed you. And in summary, I just want to remind you that data are needed for all phases of cancer control planning, that you can use all types of data to make your case and propose to show facts regarding cancer in your area. Population-based registries are useful in all phases of cancer control planning, and resources are available to you. And we're always here to help. So I think that's it.
Great. Thank you so much, Betsy. That was excellent. I asked for questions in chat. I saw, Kolisali, that you said you're happy that Betsy is talking about children's cancer. That's excellent. Ben, if you have a really quick comment or question, we can do that now, and then we want to move quickly to our case presentation.
Go ahead and do your case presentation. I'll come
Okay,
back.
great.
Thanks.
Thank you so much. Thanks so much. Dr. Suraj from Sri Lanka, I see that you're on. Are you able to share your slides on your side? Okay, great. Now, we cannot hear you if you're speaking, so you may need to unmute as well.
Hello.
There we go. Yes, we can see your slides and we can hear you now. Can you hear us?
Yeah. Hello. I am Dr. Suraj, representing Sri Lankan team. So my colleagues are also joining for this discussion. So next 10 minutes, I will present the topic, few slides related to monitoring and evaluation of National Cancer Control Program. So I will confine to Sri Lankan setup, and I will give you overview how we have arranged monitoring and evaluation of National Cancer Control Program. So before that, I will just give a few slides regarding describing cancer burden in Sri Lanka. In Sri Lanka, so you all are aware Sri Lanka is just below Indian subcontinent, and our population is 22 million. So annually, about 32,000, 34,000 cancers are detected in Sri Lanka, reported in Sri Lanka, where we have a mechanism to collect newly registered cancers from all cancer treatment centers, as well as we are collecting data from all point of diagnosis, where pathology, histopathology, hematology, and oral pathology is there. So we are trying to cover the entire country for that exercise, where we used to publish national cancer incidence data. So in addition to that, we are embarking on one district to get accredited from IARC for population-based cancer registry. So the first time we submitted our data to data call of CI5 this year. So we are optimistic that our submission will be accepted for the CI5 12th volume. So that is for Colombo district. But I am present in the entire Sri Lanka, because in Sri Lanka, health cancer care is delivered free of charge. So it is assumed that majority, more than 95% of cancer patients are seeking treatment from the government health system at any given point of time. So we have continuous data from 2005 to 2019. Over the years, data capturing also it improved. So even though we noticed that increasing trend, we need to consider that data capturing improvement over the years also. Then among males, oral cancers, lung cancers, colorectal cancers, esophagus cancers are the commonest cancer among males. Because beetle chewing habit is more prevalent. About 25% of males are consuming beetle chewing, and about 8 to 9% females are also consuming. So therefore, lip, tongue, and mouth cancers are the highest cancers in Sri Lanka among males. When we consider females as other countries, as most of the other countries, breast cancer is the commonest cancer. 4,500 breast cancers are detected per year. Then thyroid, colorectal cancers, and cervical cancers are the commonest cancers among females. And when we consider mortality among males, it is lung cancer deaths are the commonest. About 1,000 lung cancer deaths are happen per year. Among females, commonest cancer death is caused due to breast cancers. About 700 deaths are occurred per year. So when we consider National Cancer Control Plan, Sri Lanka came up with National Cancer Control Policy in year 2015. So still that National Cancer Control Policy is agreed upon. We are expecting to review our National Cancer Control Policy around 2025. Then our practice was developing 5-year strategic plan. So in 2020, we developed the latest national strategic plan, where the NCCP also evaluated our national strategic plan, and they assessed, and they were very happy and above average our national strategic plan. So with national strategic plan on prevention and control of cancers, so, few other strategic plans are also operational, aligned with national cancer control strategic plan. One was because Sri Lanka was selected as one of the WHO focus countries for childhood cancers in our region. So we developed national strategic plan on childhood and adolescent cancer care from 2021 to 2025. Then national strategic framework for palliative care from 2019 to 2023 is also operational. It covers not only cancer, all other disease entities where palliative care is needed. So this that document also the first time where Sri Lanka developed national strategic plan on palliative care. Then to go with the elimination target of cervical cancer, WHO, with the support of WHO and other stakeholders, we developed national strategic plan to reach the interim targets of cervical cancer elimination. 10-year plans we have developed. So when we consider operationalizing national cancer control plan, we need to work with all these 4 strategic plans, and it is aligned with main national cancer control policy, as well as NCD policy and national health policy. Then under the national strategic plan, we have identified 7 key strategic areas, and under each strategic area, key activities, major activities were identified, activity framework, timeline was developed, and results framework also developed. And all these documents are available online at our website, National Cancer Control Program website. So from leadership, advocacy, governance to primary prevention, early detection, diagnosis and treatment, the cancer information systems, palliative care, and cancer research are the 7 strategies on where we are working on. This is our organizational structure for cancer control in Sri Lanka. So our topmost body under the Ministry of Health, our topmost body is National NCD Council, where in addition to Ministry of Health, all other relevant ministries, it may be Ministry of Youth Affairs, Ministry of Education, Ministry of Home Affairs, like other ministries are also interlinked at National NCD Council, which is chaired by the Honorable Minister of Health. So normally at least 2 meetings are conducted per year. Our main monitoring body at the highest level is National Advisory Committee on Prevention and Control of Cancers. Secretary Ministry of Health is the chairperson of that advisory committee, and our director is the secretary of this National Advisory Committee. And my unit is coordinating on behalf of National Cancer Control Program, this National Advisory Committee. So from the Secretary, Director General of Health Services, and all other national key stakeholders, development partners, and provincial ministries of health and provincial partners are joining for this National Advisory Committee. The first quarter meeting will be held on this 18th, this Friday. Then for palliative care, under the Director General of Health Services, we have National Steering Committee, where in addition to cancer palliative care, other disease palliative care is looked after in this steering committee. Then Ministry of Health is divided into different technical areas among senior medical administrators called the Deputy Director Generals. We are under Deputy Director General in non-communicable diseases. So under her, our Director National Cancer Control Program is function. For that, under the Deputy Director General NCD, we have technical advisory committees of major technical areas where technical experts get together, and every quarter they qualitatively look at our national plan, operational plan, whether our strengths, weaknesses, and try to overcome limitations. So every quarter we have these national technical advisory committee meetings for these different areas: primary prevention and early detection, oral cancer, diagnosis and treatment, cancer registration, and childhood and adolescent cancer care. So the recommendations of technical advisory committees are communicated to the National Advisory Committee. So just we completed all technical advisory committees for first quarter, and our director is summarizing those recommendations at the next advisory committee on cancer control to be held on this Friday. So that is the national level monitoring and evaluation mechanism for cancer control. Then when we consider implementation of cancer control activities, we need to consider national level institutions where line Ministry of Health is responsible. So all teaching hospital, provincial general hospital, district general hospital, all major tertiary and secondary care is coordinated by line ministry institutions. So it is represented at the National Advisory Committee, and so through these links we communicated and monitored cancer care delivery. In addition to that, in addition to National Cancer Control Program, other public health programs also coordinated some areas related to cancer control. Now, Family Health Bureau is the focal point for maternal and child health care in Sri Lanka. Under reproductive health program, cervical cancer screening program is conducted through the Well-Woman Clinic program. So it is the National Cervical Cancer Screening Program. So Family Health Bureau is coordinating that, and it is being reviewed at the Family Health Bureau level as well as the national level at the National Advisory Committee level. Then Directorate of Non-Communicable Diseases, where the heart disease, diabetes, stroke, and other non-communicable diseases are coordinated at the national level. So primary prevention approaches through healthy lifestyle centers are coordinated by Directorate of NCD, and we are also aligned with them to operationalize our primary prevention of activities related to cancer, where it is a combined approach with other NCDs. Then epidemiological unit, where the national immunization program is coordinated, where human papilloma HPV vaccination and hepatitis B vaccination is universally introduced in Sri Lanka. So they are implementing the program and they are monitoring the HPV and hepatitis B virus vaccination program, and both programs are more than 95% national coverage is there. Then state and urban health unit, which is a marginalized population area, try to cover. So they are also we are working with them to operationalize cancer control activities at the states and urban health areas. Then Directorate of Occupational Environment Occupational Health Unit is coordinating environmental and occupational health related activities. So we are working with them to minimize cancer-related environmental and occupational risk. So that is the mechanism at the national level. Then each country is divided into 9 provinces, and provincial and primary healthcare is decentralized. Provincial ministries of health is delivering, coordinating the primary healthcare. So primary healthcare, we have hospitals where curative care is offered, as well as we have public health arm where the medical officer of health system is there, where MCH, maternal and child health, immunization, and primary prevention activities are operationalized. So we are working with provincial director of health services, and under each province, 3 or 4 districts are there. So we annually we are conducting district cancer control reviews, either through Zoom or by visiting each district to review the program and identify the strengths and to overcome the limitations. So this is the implementation plan at the national level, implementation, monitoring, and evaluation plan for National Cancer Control Program at the national level. Then I am all of my teammates are stationed at National Cancer Control Program. So we have director, deputy director, and we are divided into different technical areas, and one of the consultant is responsible for each technical areas. So I am responsible for the strategic management information unit, where National Cancer Registry and monitoring evaluation activities are coordinated centrally. In addition to my colleagues who are participating for this program, they are looking after each technical area. It may be primary prevention, it may be diagnosis and treatment, or palliative care, or oral cancer. And so at our institutional level, the national strategic plan, we are closely monitoring, and each unit is given allocated responsibility of relevant strategic objective area, and each unit is closely monitoring the major activities, 5-year activity plan, and if the activity is achieved, it is colored in green. If it is not achieved, it is in red. If it is halfway, it is in yellow. So each activity is monitored at the central level, the major activities. Under each this SO1, SO2 means strategic objectives. So at one unit is responsible for each strategic objective. Then in addition, with the national strategic plan, we developed a results framework, because WHO, World Bank, UNFPA, JICA, all our development partners are requesting us to develop results framework. So we have developed our results framework, and we are supposed to monitor annually whether we are heading for achieving results framework or whether we are lagging behind. So results framework is also published, and it is with National Strategic Plan, the same publication. It is available, and anyone can download if you log on to our website. In addition to that, we have developed monitoring and evaluation indicators for these activities, and each unit is monitoring using these monitoring and evaluation indicators also. So we are in the halfway this year for the 5-year plan. So we are expecting some there will be possibility for external evaluation, midterm evaluation, independent evaluation, either externally or Sri Lankan colleagues outside of National Cancer Control Program need to midterm evaluate our progress. Then, as Besti mentioned, the main monitor and evaluation tool is National Cancer Registry. So we have published up to 2019 National Cancer Registry, and they are available online, as well as according to the requirement, the major to fulfill all the criteria for population-based cancer registry. We have selected one district, Colombo district, and we are running population-based cancer registry in Colombo district, where data from point of diagnosis, point of treatment, and the mortality data all are included and matched. So it is available online, and we have submitted our data for the CI 12 publication also. Then being Sri Lanka selected as a focus country for childhood cancer, global initiative of childhood cancer, WHO supported us to develop childhood cancer registry with the St. Jude Global Alliance, because Sri Lanka is member of St. Jude Global Alliance, and they shared SJKR's registry to Sri Lanka. So we are maintaining hospital-based cancer, pediatric cancer registry using St. Jude Alliance, St. Jude Global Alliance, SJKR's registry, and for that we developed childhood cancer registry, and up to 2019, up to 2020. So all these publications are available. So it is being used as one of the M&E tool for further review, monitor the cancer control activities in the country. Then this is our information flow from primary care to the secondary care up to tertiary care, where patient movements, patient pathways are monitored. So at the moment, we are trying to operationalize with e-version. At the moment, paper-based versions are there, and so we are trying to operationalize and through introduction of electronic version this year. So hopefully, we are optimistic that at least part we can move into the digital version this year. So at the primary care level, our main service entry points are healthy lifestyle centers for primary prevention related behavior related interventions, and well-woman clinic program for cervical cancer screening and breast cancer early detection. Then dental clinics are the entry point for oral cancer examination, oral cancer screening, where high-risk groups are directed. So through these pathways, the cancer patients, if the patients are positive, clients are positive, they are referred to the secondary care, and if the laboratory confirmation is there, they are registered at the cancer treatment centers and hospital. So they are included in the hospital-based cancer registry. And if they need palliative care, they need to be registered at the palliative care consultant. So this is the patient pathway, information pathway from primary care to secondary care and up to tertiary and palliative care. Then this is one example where National Cancer Control Program is totally coordinated. That is oral cancer screening program. So our approach is we have declared high-risk behaviors and invited people with high-risk behavior, those who are chewing betel, those who are smoking, those who are consuming regular alcohol, or any other consuming any tobacco or alcohol products. We are inviting them to come to the dental surgeon. More than 700 dental clinics are in the community for oral cancer screening. So sometimes primary care health workers, those who are in the ground, may refer, or they voluntarily may come to the dental surgeon. So dental surgeon will evaluate, and if there is suspicion, they will refer to the oromaxillofacial surgical unit, and there are where biopsies and initial management will be done. If it is fully blown oral cancer where radiotherapy and chemotherapy is needed, they will be referred to the cancer treatment center. So so this green line now where the health institutions are located. In pink, it is the forms for monitoring purposes we are using. At the moment, this whole system is paper-based. We are trying to convert it to the electronic format. Then this is another example, our palliative care pathway, where patients are identified, those who need palliative treatment at the cancer treatment units, and they are referred to the palliative care consult services, which are located at the cancer treatment centers. All the centers at the moment, we don't have palliative care consult services. Our palliative care unit is trying to establish palliative care consult services in all 28 cancer treatment centers. So our ambitious plan is towards end of this strategic plan to establish all 28 cancer treatment centers palliative care consult services. So palliative care consult services will provide interdisciplinary care, and and they will use this shared care clinical record to refer the patient to the primary care. Then primary care level, the primary care medical officer evaluated and offered the service with the advice of the palliative care consult service. And last 2 years, about 80 public health nursing officers were appointed to the selected areas. It is only about 15% at the moment cover the geographic area. So public health nursing officers are visiting homes if they need home-based care. So that is the arrangement at this moment for delivery of palliative care from tertiary care to the primary care. For monitoring of palliative care services also, palliative care registers are introduced at each level, and all these registers are at the moment paper-based, not electronic based. So we are trying to move into electronic based. At the moment, totally it is paper-based. So our operational monitoring points are, if it is a public health program, medical officer of health office is the coordinating office at the field, where our public health midwives, public health inspectors, well clinics are coordinated and monitored. So MOH office is country is divided into about 350 MOH officers. So public health arm is monitored to the MOH office. Then primary care arm is monitored by the primary care institutions. Healthy lifestyle clinic centers, public health nursing officers are attached to primary care, and dental clinic. So all these are coordinated at the district level by the regional director of health services. Every district we have one RDHS, health administrator. Then we have 9 provinces. So RDHS is accountable to the PDHS, and PDHS is coordinated with the National Cancer Control Program for foreign services. To monitor the delivery of palliative delivery of cancer care services at the primary care, we are conducting reviews at this level, district level. So country is divided into 26 districts. So we need to conduct 26 district reviews annually. So this is our activity. So we used to conduct either through Zoom district reviews or in-person district review. Last year, totally we had to conduct Zoom kind of district review because of COVID outbreak. So this year, our plan is to conduct in-person district reviews by national team is going to visit. All program managers in the national team will visit each district to conduct district review. So we looked at quantitatively, qualitatively, and we discussed challenges and identify solutions also. So so this is my initial presentation. So all these 7 strategies we are trying to monitor at the national level, provincial level, and district level. So last 2 years, because of this COVID outbreak, the health priorities were changed. So whole system was highly disturbed. So we are trying to revive this year to again put on to the track of implementation, monitoring and evaluation of cancer control activities in the country. So those are my initial presentation, and my team will also join with me if there are any queries to be answered. Thank you.
Thank you so much. That was a really great presentation, and I think gave everyone, excuse me, a lot to think about and a lot of great examples of how you guys are incorporating monitoring and evaluation into your overall approach to cancer control. I really do appreciate it, and your slides are fabulous. So thank you so much for the time and effort that you put into your presentation. We don't have a ton of time for any questions, but I would ask if there are any, immediate questions, please take yourself off mute and go ahead and ask that question. Otherwise, I hope that we can continue this dialogue and these questions on Basecamp. But let me stop and see if anyone has any pressing questions. Ben?
I'll make this real quick. I thought both of those presentations were dynamite, and I really appreciated it. This is a cancer registry question, which is, we talked about population-based cancer registries, and we just heard a great example of really doing awesome work in a limited resource environment. But most countries can't leap into doing population-based data recording. Creating SEER took a while. How do you decide when regional cancer center collection is adequate for representing the population?
I think that's a great question. And I think there are a few approaches. And one might be to really try and limit data collection to a single region in the country, a smaller geographic area, and trying to capture all of the cases in that area. One of the things that we as epidemiologists get concerned about with data from a cancer center is that you might get referral patterns from or people coming in from a wider area, and so your rates and statistics may be biased by that. But there are probably some ways that we can measure that. You could exclude those cases from any statistics that you do as being outside of the catchment area. And hospital data is of value. It's not to say it's not of value. You do get quite a bit of information from hospital registries, and I think you can use other information to interpret the data. So, for example, if you have a surgeon who draws from a wide area, you can say, well, we might have an excess of this type of cancer, but it's because they're coming from a wider area because of a particular practitioner. So, use the data and use the local knowledge that you have to explain it, and use your information to temper the conclusions with what you know locally, I would say.
All right, thank you for that question and for the answer. I'm putting things in, I know we're running out of time, I'm putting things in the in chat. I think we'll wrap up. Clay, do you wanna, or Echo, do you wanna launch the evaluation poll? Thanks. So thank you everyone for coming so much. I think this has been really, really good. We just really, really appreciate both Dr. Kohler and Dr. Scrooge for your presentation. Super informative. Let's continue the discussion. We kind of ran out of time today, but let's continue the discussion on Basecamp. It's a great opportunity to ask questions and answer questions and get other resources that people know about. So please go ahead and visit Basecamp. Couple reminders, our next session is April 20th. It's going to be about improving service delivery through your cancer plan implementation. We will, as usual, send out some pre-questions before that. And just a heads up, Uganda, you will be the case presenter. So again, really appreciate everybody's contribution today. Thank you so much for showing up, and we will see you on April 20th. And in the meantime, we'll talk to you on Basecamp.
Thanks, everybody. Great to see you.
Bye. Thank you.
Bye, everybody.
Thanks, everybody.
Good night.